Hi, Krishni. I can confirm that we are now live streaming.
Thank you. Morning, everybody. Welcome to our Integrated Care Board meeting in public for NHS Herefordshire and Worcestershire. And delighted to see you all here today after a slightly strange summer, I think, in terms of changeable weather. But here we are, and looking well. We've got a winter to think about ahead. But welcome everybody. I know we've had a few apologies, certainly from Paul Robinson and Paul Walker. We have Darryl Freeman joining us later, who's the Director for Children and Young People for Herefordshire County Council, or Herefordshire Council, I should say, who's going to be presenting the report on the Herefordshire Children's Services a little bit later on the agenda. We also have apologies from David Mahaffey. Otherwise, I think we're good to go. So a warm welcome to everyone. Declarations of interest, please, for items on this agenda over and above anything you might have declared for the normal register that's available. Okay, take that as none. Thank you. So we'll move on to the governance log, which includes our forward plan. Now, I think there were a couple of items, Hannah, that we will be moving to a different schedule. Do you want to just talk us through that? I think we originally had a plan for a workforce item to come today, didn't we? So over to you, Hannah.
Thank you. Yes, Krishni. So that will come now for our next meeting in November. So that is just to note, the forward plan should have been amended accordingly. The other thing I just wanted to pick up from the governance log is there is an action log within the governance log. So all the actions have been updated. They are either closed, ready for closure, or open because they're not due until the next meeting. However, there is one action related to dermatology briefing paper, which is marked as complete, but the paper has in fact not been circulated yet. It's expected to be done so by the end of this week at the very latest. So just to note, that's a kind of amendment to the governance log. The only other governance point I wanted to make sure we raise is that we are quorate for the meeting today, which we need to acknowledge in our minutes. I don't think there's anything else, Christian, that I wanted to raise.
Thank you, Hannah. Any questions on anything within the governance log or the board forward plan? Okay, thank you very much. We move on then to the minutes of the previous meeting, which was our meeting of the 19th of July. They're there for our approval, and just want to confirm whether there are any points of accuracy before we approve them. Everyone's satisfied they're an accurate reflection of our meeting. Great, I can see lots of nods, so I take that as a yes, so we'll consider those approved. Thank you. So I believe, moving on to our patient public voice section, that we have no questions from the public today. So we'll move straight into our patient story. And for that, I'll hand over to Dr. Kath Cobain.
Thank you very much, Chair, and good morning, everybody. Today's patient story will focus on a young boy and his mum. The story is shared with the permission of the family, and different names have been used to protect the confidentiality of the family. Children and young people with special educational needs and disabilities have experienced cumulative effects of disruption caused by the pandemic on health, learning, and development. The impacts on children and families include missed and narrowed education, the absence of essential services such as physiotherapy or speech and language support, and long waiting times for assessment and treatment. This is the story of one of those families in their journey to a diagnosis of autism. This is Theo's story. As a baby and toddler, Theo had a history of poor sleeping. By the age of 3, his mum, Angela, contacted the health visitor with concerns about his speech development. An audiology assessment confirmed no hearing concerns. He was therefore referred to speech and language therapy. The referral to assessment took 5 months, which was likely impacted by the initial pandemic response. Despite commencing speech and language therapy, his condition did not improve. Further reviews identified Theo may be autistic. Angela had been advised he could not be referred for a diagnosis until he was nearing school age. Angela was unclear about the referral process, but believed the referral had in fact happened, and she understood the waiting list was long. 6 months later, she contacted the service and was informed the referral had not been received and a re-referral had to be made. Theo continued to struggle at preschool despite receiving intensive speech and language therapy. Angela described this period of waiting for an outcome as exhausting, agonising and frustrating. The assessment and diagnosis took over 12 months to complete. Once Theo received a diagnosis of autism, he was offered an education, health and care plan quickly and efficiently. A course for parents of autistic children was also offered, but Angela felt that it lacked the specialist information required to help her support Theo. Following diagnosis, it took over 4 months for the education setting to put the advised support in place, and Angela felt that she needed to battle to get it. Once in place, it was very beneficial to Theo and his family. Angela feels she has had to continue to oversee the education and healthcare plan and be the linchpin of communication. She described the experience as akin to booking a non-package holiday and having to coordinate all of the elements to bring it all together. So there are a few key learning points and a few key actions, as well as links to the later deep dive, which Mary will take us through. So the key learning points, and firstly, the referral pathway was not clear, which led to delays in getting the right support in place. There was a lack of signposting to and availability of support services for mum. Waiting times were significant and communication of those were not clear. So Mary will take us through later what the work that's going on around children's and special education needs and disabilities, and lots of work is going on. But I note these key actions in place, particularly around this family. So what next for this family? So firstly, the support and training offer for parents and carers has been enhanced, which includes a menu of options for parents to choose from. The local offer, which is the statutory information advice offer, and that's statutory required on the local authority, is currently under review and is due for relaunch shortly. The offer will have specific pages for those with neurodiversity, which have been co-produced. And thirdly, and I'm sure Mary will extend on this in the deep dive, a range of stakeholder events with families, carers through surveys and focus groups has been gathered this year to inform the development of local priorities for improvement. And some of those are reducing waiting times for assessment and diagnosis, increasing support whilst waiting to include system navigation and a single point of contact, support offered by mainstream schools, including special education needs coordinators, hearing the voice of parents and carers, and the quality of EHCP, so the education and healthcare plans. So it leaves me to thank Theo and his family for sharing his story, and to back to you, Chair, for discussion. Thank you.
Thank you, Kath. A really important story to hear, I think, in terms of the delays in the process and the compounding impact that had not just on the experience of the family, but on potentially on the outcomes for the young person. I know we're going to be talking more about this later, but I think there is an opportunity perhaps just to understand if there are any aspects that we're not likely to be picking up later. Is there anything that people want to explore as part of the story, as opposed to wait for the later item? Nikki Berger, please.
I think it would just to pick up through this, that during due to the delays, a lot of families are going outside the NHS for assessment, and that's then creating a duplicate system where they're getting assessed outside, often then coming back to their GPs to institute treatment plans back within the NHS. But we don't know how these other providers are regulated, you know, whether the diagnosis is correct. We don't have enough information about that in primary care, so I think that can be a difficulty, because often medication's recommended that they want the GP to continue, and then you're not sure about, you know, the other providers.
Yes, thank you, Nikki. It's a really good point, an important point, and perhaps we can pick that up as part of the later item, because it's certainly something I've heard about before, because the problem with getting diagnosis is, I think, widespread, certainly across the region, I'm assuming across the country, and the private provision and the sort of connectivity and interface between the private providers and the NHS is an issue I've heard about before. So I do think we ought to come back to that and just explore how we might, or what our current thinking is on that. Let's just take a few more comments and questions. Graham, please.
Thanks, Krishni, and thanks, Catherine. Catherine, this may touch on the discussion later, but I'm just interested in to what extent, in your view, the issues faced by the family were localised with resources, or are they more systemic, national issues in the whole way the system works?
Cass, do you want to respond to either of those points now?
Yeah, I can probably give a broad, and then Mary will obviously be able to give more specific. I think this is a national issue, Graham. I think there are struggles across the whole country, and obviously there's been some really good local work that Mary and team have done, and probably want to talk about in the deep dive, particularly from the joint Ofsted and CQC inspections for that have been done in Worcestershire, and that there's been a mock one done in Herefordshire as well. So a lot of specific improvements that we can do locally, but I think yes, this is a national issue as well.
Thank you, Kath. Sarah Raystrick, please.
Thank you. Thanks for that story. Just a question really from a public, anyone who might be listening perspective who's heard that story of Theo. His mum does sound like she'd got quite a lot of agency. She was able to, she spoke to the health visitor, she knew what to do and yet still face some difficulties. You did mention that she'd been told either erroneously or correctly to wait until Theo was nearly school age. Where would you signpost people to if they were hearing this story? Would it be to a website, to a GP? What would be the right thing for someone in Herefordshire and Worcestershire to do if they'd got concerns about their child? Obviously bearing in mind that every child is different, but what would we advise?
I think, Sarah, probably a number of routes. You know, the health visitor is the universal service for everybody, and we have intensive health visiting for those who require more as well. So absolutely, for a child under 5, having a conversation when your child's not sleeping properly, not eating properly, various things, the health visitor would be, I would say, the first point of contact. The local authority, obviously through the information and advice, working very specifically, and that's their statutory duty around that information and advice, to make sure those web pages are up to date and there's contact details and everything there. So there are those things, and looking through specifically around the send offers. There's a thing called the information and advice service. So I think it's more about how these things align together, and Mary may touch on this in her deep dive, because I think that's the first point of contact. I would health visitor most definitely.
Thank you, Kath. Thank you, Sarah, for the question. Nigel?
It's a very similar point to the point Sarah raised, really. It struck me that the family were having to do a lot of coordination here throughout their journey. And you know, that that potentially widens inequalities if you've got people who don't have the resources to be able to do that. And I just wonder whether we should be thinking about building in a single point of contact where actually we can lessen the burden on families to try and have to pull things and coordinate things, and that really stood out as a potential learning point for me.
Yeah, thank you, Nigel. I mean, I think it's a sort of something we need to ask ourselves in relation to a lot of services, because perhaps for some, any of us who've had family members who older adults, for example, who needed care and services. I've certainly personally had the experience of being able to navigate because I knew the health service better, and I was better able to set expectations of what I needed and what my mother at the time needed. But I think it's very hard for people. It's a very complex set of things in front of people, and the more we can help to navigate that, the better. So I think Kath might have mentioned the possibility of single point of contact. So, and I know Mary has indicated she wants to come in. So Mary.
Thank you. Yeah, Nigel, it's a really important, pertinent point. I'll come on to it later, but we were in London yesterday on a SEND policy launch with the Children's Minister, and of the 9 systems, and we're one, nearly everybody said the problem is parents don't know where to go, and we're not intervening early enough, and we're not identifying early enough some of the problems these children have. And if there was only a single point of access, that would make life easier. So I'll come on to describe our approach to that later in the deep dive. But I think it is key to this, because all the demand we're seeing is a result of families not knowing where to go. The condition deteriorates and deteriorates, and then we're having to use the high level services to intervene. So we need to bring it forward 3 or 4 years was the message yesterday for these young children.
Thank you, Mary, and thank you, Nigel, for the question. I mean, I think it also prompts the question about inequalities more broadly anyway, and it's something I'd like to come back to in the item that we talk about later in respect of just communities or parts of our community that might find it just even harder to navigate access, understand what's available, all of those things, and how we might be supporting those people. I've just one question, Kath, which I don't know if you can answer, but in relation to the specific story, what almost concerned me right from the beginning was a misunderstanding, or whatever the circumstances were, about that original 5 months. I can only imagine how upsetting that must have been, to think that a referral has been made, but actually you're 6 months down the road and you've heard nothing. And I'm just wondering whether there was an error there, as in somebody just didn't make the referral, and why then we make the person wait again, if that is the case, if it's our error. So it was just a question about that particular, because I suspect that very opening sequence of events in itself created, set a tone for what followed afterwards. So I was interested to know whether it was an error that caused that, and why we couldn't just then prioritise somebody who perhaps should have been. Kath, do you have a view on that?
Yeah, thank you, Chair. And yes, when we were putting the story together and looking at the story, and obviously there is significant complexity around accessing services, which I think we have detailed out. But when we went back to that, the referral was made, and they think there was some kind of error around it being registered on a computer and things like that there. So there wasn't an error from an error from a human perspective that the referral was made, but there was some computer error that occurred. So again, I suppose having that single point of contact while you're waiting, just so that you can check in and go and recheck back, is a really useful resource. So you wouldn't be waiting 6 months, then you would be having a regular check-in to do that. So I think that would have definitely helped.
And I think the point about what happens while somebody is waiting, which I think somebody made earlier, that if we can be providing support whilst people are waiting, then that might alleviate some of that experience of concern whilst, you know, as I say, whilst you're waiting for the service. Final comment then from Nigel.
Yeah, just a quick one. Obviously, from a general practice point of view, we do see these problems around referral, and most providers are really good, actually, whether it's been a sort of a system issue, do make an allowance. But I think we should, but not all providers, interestingly. So I think it would be a good thing to sort of build into commissioning, really, that actually where there is no fault referral delay, that is acknowledged and an allowance is made for.
Yeah, Nigel, thank you. I do feel that is important. Otherwise, the process is penalising people, even though through no fault of their own, really, and that doesn't seem fair at all. So, I do think we need to think carefully about things like that, and it's the ability to be flexible in some of our processes, I think, is important in that context. Thank you. So, Mary, if we can come back to a couple of those issues, I think it would be helpful, or at least in talking to the item later, perhaps we can touch on inequalities, the single point of access, and support whilst people are waiting as sort of elements that you might just want to draw out, so we can really help understand a bit more about those challenges. Thank you very much, and thank you to Theo and his family for sharing that story and really giving us an insight, I think a really important insight on the challenges that are currently faced by people waiting for those services, and hopefully we can come on to improvement opportunities later. So thank you, Kath. We'll move on then to our Chief Executive Officer's report. So over to you, Simon.
Thanks, Krishni. Good morning, everybody. It'll be good to pick up on some of those children's services issues later, because we talk a lot, don't we, about prevention and reducing health inequalities. I think probably the biggest area, biggest opportunity is probably in the services that we offer for children. So it's the right thing to be talking about, because we think we can probably make the biggest difference, can't we, if we get the right children, the right families at the right time. So it's great that it's on the agenda and it's getting the airtime. Hopefully people have had a chance to read the report. Really comprehensive, and we're grateful for Hannah for pulling it together, and for the whole team, actually, who all contribute bits of information. It's stark, really, to me, the breadth of work that we're involved in, and hopefully that comes across in the report. Just to pick out, as usual, a few points. So there are a couple of things we're asking for approval from the board today. So firstly, to sign up to the Sexual Safety Charter that was attached as an appendix, and secondly, to endorse the use of the ICSY Sustainability Impact Assessment to add to our impact assessment toolkit, if you like, that we use when considering proposals and actions that we should be looking at sustainability as well. Just in terms of the report, lots of publicity over recent weeks about freedom to speak up, and a really stark reminder of just how important it is that we create the right culture across our organisations, where staff, particularly those on the front line, want to feel able to raise concerns, and secondly, that we're doing enough to promote that, really. So stark and telling reminder. Thankfully, it's Freedom to Speak Up month in October, and there's a number of things that we've got planned, both within the ICB, but also actually across the system and organisations, to really push that. So I think it's helpful for the board to be aware of that. Vaccinations have started, and that's just our process for that is described at the bottom of page 2, and we're grateful for colleagues within the team, but also colleagues within general practice who, as ever, carry the burden of most of this, and I'm sure will do a fantastic job in helping to protect our population over the coming weeks. I can't summarise the report without mentioning industrial action. So big day today, and actually the report isn't quite clear that today is the first day where we have got junior doctor and consultant strikes overlapping. There are strikes all week this week, but on Wednesday today, we've got both of those overlapping. So huge strain on operational services. We're able to run Christmas Day services today, which is far from ideal for a Wednesday towards the end of September. A lot of effort has gone into preparation and planning, and we're hopeful we can keep services safe and accessible today, but clearly there's a significant impact of such a high proportion of the workforce not being available to undertake their roles today. Another couple of things worth pointing out on page 5, the GP patient survey, which is an annual survey of patients of GP practices. Once again, our general practice in Herefordshire and Worcestershire continues to perform well on almost every metric, really. I think the one that stood out that we've highlighted in the report, we've got the highest level of patient satisfaction with their overall experience in the whole of the Midlands region, and the 6th highest nationally as well. So credit to the GP practices and PCNs for the work that they are doing there. And then just a couple of things to finish. So firstly, Mark's asked me to report that we have appointed an external auditor now, Deloitte. You remember a complication with our previous auditor who had taken up some other work, so was basically unable to be independent as our external auditor, and a complication that the accounts they have to audit for 22-23 include 3 months of CCG accounts and 9 months as an ICB. So a little bit of a different year. We have appointed somebody, and we would hope that that audit work gets completed at some point before the end of November, ideally, so that we can publish an annual report, we can publish our accounts, and we can hold our AGM as well, which I know we are a bit later than we would usually like to do, but that will all happen in November. And just to finish on 2 people things, so there are a couple of system leadership changes. So we're going to welcome Stephen Coleman as the Managing Director of Worcestershire Acute Trust, and Stephen's going to start at the start of November. And Sarah, who's obviously a board member, has announced her intention to retire. She'll go with our very best wishes and gratitude, and I'm sure there'll be plenty of opportunities to thank her for her contribution. But I thought it worth marking today that Sarah is now working our period of notice. And finally, good luck to the One Herefordshire Partnership, who you'll see from the report will be nominated in the Health Service Journal Awards. And that's a fantastic achievement, actually, to make the shortlist. So good luck to Jane and team at the awards ceremony. Happy to take any questions, Christian, on any of those items or anything else.
Thank you very much, Simon. Colleagues, any questions or comments about the report or anything else? David, please.
Thanks, Christian, and thanks, Simon. Simon, I have a number of comments, so I'll ask the questions and just all in one go, if that's all right, and you can kind of come back to them as possible. So on the Sexual Safety Charter, absolutely welcoming that. What worries me a little bit is that when you look at the charter commits us to working towards ensuring it's in place by July 2024. I feel quite uncomfortable about being committed to working towards. I feel very comfortable about being committed to implementing it by July 2024. So I wanted just to be clear where our commitment is on that. That's the first kind of comment. Second comment was on the vaccination update. You put something about there's a hard stop for all eligible cohorts for the COVID-19 vaccination on 15th December. What does that actually mean by that hard stop? If you could explain that would be great, thank you. On the industrial action, we talk about the significant impact on staff well-being and morale, and I'd like to receive either here or perhaps in a different forum an update on the actions that we're taking to maintain morale across the system. I think that's really important in order to keep things going. I really welcome, of course, the primary care report and how well we're doing on primary care. I often bring up the following point, which is what are we doing, or what assurance do we have that this performance can continue, because it's so critical for the system as a whole. So I wanted to ask for assurance on that, and I think that's probably enough questions for the time being, Simon.
Thanks, David. Just to go through those in order, so I agree with you, we will implement the charter by July 24th. I think that would be a strong decision for the board to take today. That was certainly our intention. It's obviously a national programme, and lots of areas will be working towards it, but there is no reason why we can't lead the way in making sure this is implemented. I totally agree with you. Vaccination hard stop. So that is the national intention for this programme to have been completed by December the 15th. We often have such fairly arbitrary deadlines, but important deadlines, because obviously the issue being that making sure that the most vulnerable people in the population have the protection they need before going into what's traditionally the influenza season. And if you remember last year, we had a wave of COVID that coincided with the influenza season that came just before Christmas and over Christmas and early in January. So actually, there's a very good, sensible clinical and operational reason for trying to get this done by the middle of December, and we'll intend to do that. The reality is, even though there's a hard stop and a target deadline to complete this, what happens is there will always be follow-up and wrap-up actions as we go on, but it's good to set a target that people aim for having the most universal coverages by, and that's what's referred to. Primary care access, look, it's an ongoing issue, isn't it? We have every intent strategically, don't we, to try and stay near the top of that league table. We've built our system operating model almost on the strongest general practice and the strongest primary care networks. We're so reliant on them for so much, and we're really committed, actually, aren't we, through the work that we're going to do on implementation of the Fuller Review to make the primary care networks even stronger. So you can never offer guarantees, David, because ultimately this is reliant on the good work that colleagues in general practice are able to do for us. But what I can guarantee and I can assure the board is that as a team, and I know as a board, we're fully committed to doing whatever we can to support the continuation of this high performance. That requires protection of investment. It requires practical support in lots of instances. It requires some lobbying sometimes of national policy, which Nigel in particular is quite effective with. So there's a whole series of things that we'll be trying to do to protect that relatively good access that we have, because it's so important. And I think that, the actions on the industrial action. So yeah, I think that would be a good thing to maybe include next time, a bit of a stock take on, because I'm well aware that Katie and the people in HR leads there's a lot of work going on around cultural reward and recognition, support for staff in frontline roles. That's more important than ever, isn't it, during what we're going through at the moment, which is a period of industrial relations turmoil that has an impact, actually, not only on those staff groups that are taking industrial action, but also on the rest of the staff groups who often have to take compensatory actions to work around the fact that their colleagues aren't in work at the moment. So I think that would be a good thing to reflect and take stock on. So maybe we'll, through Katie, we'll try and include something next time a bit more formally to capture some of that.
Great. Thanks.
Thank you, Simon. Thanks, David, for the questions. I mean, Russell, I know wants to come in, so might want to comment on Russell from a chair perspective or a board perspective and providers, what sort of the support for staff and morale in the context of industrial action. But I'll bring you in if you want to comment on that. That would be helpful. Thanks.
Well, first of all, I just wanted to thank Simon and his team. As ever, the quality of the Chief Executive's report and the quality of team working generally across our ICS, I think, is extremely commendable. I did want to pick up on the issue of industrial action, but start off with a public apology, which I have made in both boards, to our citizens. This industrial action and the problems we have at Worcester Acute in particular with the ambulance stack causes real emotional and probable harm to our patients, and I'd like to apologise on behalf of the system as well as the organisations I chair, that we need to do a better job in terms of resolving that. I fully appreciate all the enormous efforts of our frontline teams to endeavour to give the very best service that we're able, and it is made enormously more difficult through this industrial action, and particularly when the consultants and the junior doctors go on strike. I am concerned about staff well-being. We're doing a lot in Wye Valley and at Worcester to try and support our staff, but I am very conscious that the unheard voice very often are members of the public stuck in the back of an ambulance, waiting to get into an A&E and waiting for a discharge. So lots of work for us to do. So apologies to our citizens. We're on it. We have the plan to improve the situation, but on a daily basis, we know there are real difficulties. Thank you, Krishni.
Thank you, Russell. Really appreciate that, I think, and welcome that openness and ownership of our collective challenge. And of course, we're here to support everybody with those challenges. Okay, I think there's Jane, do you want to come in?
Yeah, first of all, congratulations for Worcestershire's Children's Services and their Ofsted rating. So really delighted to see that. And I guess my question is, probably to Mary now, but to Darryl later as well, in terms of, are we making sure that all of the lessons that they've learnt in Worcestershire, we're taking full advantage of that on the Herefordshire improvement journey?
Yeah, thanks, Jane. I think that's it's a really good question. We should probably come back to that, as you say, and absolutely support your congratulations for the improvements in Worcestershire, which definitely need to be acknowledged. Thank you, Vicky.
Thank you. I just wanted to ask about the point prevalence in terms of our consideration of what the key areas are that would have improved so that we can see a difference this year with the point prevalence. But I think just picking up on Russell's point about the industrial action, about whether actually with this timing of the industrial action, whether actually there will be any difference or perhaps a deterioration in that position.
Thank you, Vicky. Point prevalence, do you want to comment on that, Simon?
I mean, the key areas of difference we're always hoping to see is we're obviously hoping that we are able to make progress continually on less people being in the wrong place in the wrong part of the system. My gut feeling and looking at the numbers is we have made quite a bit of progress with that during the last 12 months in both counties, actually, probably a little bit more in Worcestershire. And I know it's a key area of focus for Jane and the partnership, is just to continue striving to get that level of movement in Herefordshire. I think there is a bit of an unknown with repeating the exercise this year, because we're not sure, are we, actually, what the operational impact of industrial action, particularly this week when you've got consultants and junior doctors. We've kind of learned, I think, what happens when junior doctors go on strike and how the services just about find a way through that. We've learned how we deal with the absence of consultants actually in isolated incidents. We haven't yet learned what happens when neither of them are there, actually, and other staff groups have to take the load. So I think it's interesting, but I think it's really important. We want the point prevalence to be an annual exercise. We just need to crack on and understand the context in which we're doing it, and then reflect when we get the outputs of that work and reflect what impact the industrial action might have had. But it's really good to point out, Vicky, and to highlight that it's a different set of circumstances this end of September than we faced last September.
And Simon, I think probably worth saying, I think the point prevalence work we've already done inform the other reference in the paper around sort of the demand and supply, the bed base. So it's probably worth just reiterating that it's part of sort of informing our strategy, and not something we were necessarily expecting to immediately be able to improve everything, but it's that the data we needed to really understand what changes we needed to bring about over a period of time. Am I right in thinking that?
Yeah, you are. That's all part of the same piece of work, and it's all about understanding what's really happening in our services. And the demand and capacity modelling that I think is about 95% done now, that has a much longer perspective, 5-10 years in the future. What will happen if demand carries on at its current level? What will happen? What will be the impact of demography, how many beds would we need if we didn't change anything, and then what are the series of interventions we could collectively make, and what impact would they then have on the bed base. And that clearly flows through to medium and longer term financial planning as well. We need to understand what money therefore we need to allocate to growing the bed base, and what money, ideally the majority of the new money, we could allocate to interventions that we could make that would reduce the need for beds in the future. And that really is the crux of the strategy. But the point prevalence work, as Krishni points out, is the start of that understanding how best to plan that journey that we're going to go on.
Thank you, Simon. Thank you, Vicky, for the question. And Russell?
Apologies for coming back in, but I just wanted to come back on something which I think is worthy of airing in this public forum, which is one of the things about the point prevalence is it's not just about the potential financial saving from having patients in the right care setting, but the evidence for hospital-acquired functional decline is enormous. And I think we need to ensure our citizens understand that hospital is not always the best care setting for themselves or for a loved one. The evidence for hospital-acquired functional decline, i.e. staying in hospital longer than you should, lying down rather than getting up and being mobile, is really powerful. So the point prevalence work is not just a financial issue, it's a health outcome issue. And I also say this in the context of my clinical colleagues who are looking at discharges, particularly pathway zero discharges. It is better for the patient to be at home, hospital at home, with more virtual wards increasingly being provided, rather than being in a hospital bed, which restricts flow and has consequences therefore on the ability of the ED to work and the whole acute setting to work.
Thank you, Russell. So that it's sort of clinical, there's a clinical behaviour piece as well, isn't it, or clinical judgment piece here as well. Really important to talk about the outcomes as well as the other longer term benefits. Graham?
Thanks, Krishni. Simon, I suspect a very simple one for you, and it's just about some assurance. On the sexual safety charter, I was just a little bit unclear about the scope of that. Is that just for ICB and the trusts, or does that cover the wider system, including primary care and POD? And the other thing I just noticed reading the documentation, it talks a lot about staff and patients, but nowhere do volunteers get mentioned. And I just want to check that all of that protection extends to our very valuable volunteer workforce.
Thank you, Graham. Really good point. Simon?
Yeah, well worth clarifying that the intention in signing up to this is that we sign up actually on behalf of the whole system. I suspect individual organisations might want to look at this in their governance structures as well, but it's almost a symbolism of we want to sign up to this as a system. Clearly we have the most influence, don't we, in the ICB on our own people, but actually the people around this board table, this virtual board table, can influence across every organisation, and absolutely it should apply to clinicians, managers, staff, volunteers, anybody who is working within our services should have this level of assurance and protection, because why wouldn't we want that? So that very much is the intention in setting this out.
Thank you, Graham, for that question. And if I can just pick up on that, I think, you know, when we think about freedom to speak up and the sexual safety charter, I mean, I think safety is the common word in both of those. You know, that this is about creating an environment in which staff feel safe and patients feel safe, actually, and our services and our support for them keep them safe. So I think it's really important. So I do see the freedom to speak up as sort of connected, because if people don't feel able to go through a formal HR process in terms of sexual misconduct or something like that, they may use freedom to speak up. So, you know, that everything we put around, all the processes we put around are to encourage people to raise concerns, to create that sense that you're safe to speak up in this environment, and I think that's a really important aspiration for all of us in terms of trying to create an environment where staff genuinely feel they're supported with these issues. And I just, in a practical sense, I think we talk about obviously the ICB role and all organisations. I think Graham's point was really important. You know, in some of these things we can focus on our own organisations versus what does it mean for the system. And I think even with freedom to speak up, I do think we need to think collectively about how we're supporting primary care, for example, with freedom to speak up. And, you know, so I think when we do some kind of, Hannah, I know we've talked about doing some kind of collective view of where we are on freedom to speak up, just to get a sense of how people are doing it and what we can learn from each other. I do think we need to think about those other parts of our system, like primary care, which may not have quite the same resource available to support them with that, and what our role is within that. So I'd like a conversation about that as part of the wider piece, and I think that applies to things like the sexual safety point as well, which Graham raised. More generally, I was just going to make the point that I think a couple of people have talked about primary care, and it was really heartening to see that the survey results again. We continued our good performance, and the response rate was higher. The currency of the feedback was higher as well. It was more recent or in year. I do think, and I'm looking to Hannah here, I think we've got primary care access recovery on our forward plan. So we have an opportunity, have we not? Perhaps even in the next board, I think, to revisit our conversations about primary care. So I just wanted to, for colleagues who just raised that question about making sure that, you know, how do we sustain primary care, the current level of performance, and indeed continue developing and improving. I think we've got it on the agenda, and we've also got that opportunity to think about how that connects to the whole fuller recommendations, I think was the other aspect of that. So we will revisit that, David. I think you raised that right at the beginning, and it is an important area. And I think the other thing that came out of that for me was the wellbeing and morale point. We have just started the staff survey process, I believe, or about to. Organisations that take part in it, which will mostly be the providers, of course, will be, or the NHS providers will be undertaking staff survey shortly, but it does take a while for it to come through, doesn't it, Katie, before we get the results. But things like sexual safety and safety culture will be very much a part of that. We may just want to think in the meantime, before we get that, what we're doing more broadly to support staff wellbeing. That might be something that we want to revisit, as others have suggested. Okay, well, and thank you to colleagues who put that report together. I would echo Russell's comment. I really enjoyed reading the report, and I thought there was a really good balance of different elements in it. So thank you to everyone who helped to put that together. So two things we need to actually sign up to, and that's the implementation of the Sexual Safety Charter, which I trust colleagues are willing to show their support for, and the ICS-wide sustainability assessment, which we would like to implement across the system. Is everyone comfortable to support both of those recommendations? Thank you. Great, thanks very much, Simon and colleagues, for all the questions. We'll move on then to the Committee Escalation and Assurance Report. So I don't know, Hannah, whether you want to introduce this, and then we can ask committee chairs if they'd like to come in at all.
Yes, thank you, Krishni. So this is the second instalment of this new format of the AAA report, the escalation report. There was a comment at the last meeting about being clearer how long items have been on alert. So that's an addition we've made. I think some of these risks can be quite long-standing. So we've kind of drawn the line at the establishment of the ICB. So if any, you know, rather than just saying, well, it's been only on alert a month because this report has been in existence a month, wouldn't really be very transparent. So where we know this is a long-standing risk, we dated it back to the to July 2022. So that's just for clarity. Otherwise, probably over to the committee chairs really to add anything.
Okay, so can I invite, probably in order, you know, don't feel you have to comment because I think it's a really comprehensive report, but if you'd like to draw our attention to anything, start with you, Vicky.
Okay, thank you very much. I won't comment on the main content because we'll be talking about this across the board paper today. But I think apart from the alert areas, I would just point the board to the assurance level where we talked about the harm review deep dives linked with the safety strategy and the new approach to reviewing safety across the system and across the providers. So it was a really helpful deep dive that will continue to look at those themes of outcomes for patients. So that's all I want to comment on.
Thank you, Vicky, really helpful. Thank you. Sarah?
Excuse me, I think mine is absolutely fine without additional comment unless anyone's got any questions or clarifications. Thanks.
Thanks, Sarah. Jane, do you want to raise a question?
Yes, when I read through this last night, it's in your area, Vicky, in terms of the alert that's come out about stroke. Because actually we know we've got very good performance around stroke and our outcomes certainly measured by mortality are very good, and it seems we're picking on, you know, one element, and actually, you know, admission within 4 hours of arrival, and the target on that is 60%, probably tells you how clinically important that one area is. So I was sort of surprised to see it on the alert, and B, where it talks about, you know, a revision to the service model is required to mitigate this performance. Actually, I don't agree with that. This is this is much more internally about all the things that you need to do to try and get patients to has you earlier. So both in terms of its clinical importance and the comment on what the potential mitigation is, I'm not sure I'm quite in the same place as the committee was.
Thank you, Jane, for those comments. I mean, I think Mary may wish to come in here and make some comments, because I think the discussion is about what needs to support stroke services going forward and some of the actions that have been taken, and indeed the consultation that's been undertaken. So Mary, can I pass to you to just make comment on that?
Yeah, thank you. Obviously, the risks have been signed off by the stroke programme board, the clinicians and the managers across the stroke programme board. And I think it's just giving some additional information to that. So we know the recommendations from the stroke programme board was twofold: to continue the work to improve the stroke services as they are now, using a range of different operational models, technology, etc., the new best practice coming in. So we're continuing to do that work, but also preparing for the future, you know, not next year, the year after, for the future of stroke services. We know the demand is going to go up no matter how much prevention we do, and what is the best model, operational model for our ICS. So we are coming through the SCC, I believe, shortly to get support to go to go regionally through the process that you need to go through for service change, to agree that we can take forward that work on stroke. Not saying we'll ultimately get there, because there's a big finance issue behind it as well, but we are proposing, and the stroke programme board have signed this off, and that we do look at the stroke model for the future.
Is that helpful, Jane?
I understand all that context. I think my point is really the specific around something that's raised as an alert, which on face value doesn't feel like it's the most important thing. Sustainability in the long term and all of those things well understood, Mary, and understand the work that's going on.
Okay, thank you, Jane. Certainly, I would say that on arriving in the system, stroke services was raised with me quite early on as a challenge that's been pervasive, I think, maybe a word I would use to say that it's been a long-standing challenge, let's put it that way. So perhaps that's what's reflected in there, that it's never quite worked. I mean, I have to use my words carefully, but it's not been, there's been a long-standing challenge, is what I understood, certainly in arriving in the system. That was something I was briefed on. So I know there's been ongoing work on that. But anyway, we can. The important thing is, I think we've had the conversation about that. It's obviously gone through the appropriate process, Mary, is what I think you're saying in terms of clarification of that risk or that concern that has gone through the stroke programme board. Okay, thank you. Right, then we've got SCC, we've done. David, anything you want to cover on from appointments and remuneration?
I wanted to cover actually that now we're using this AAA methodology, which I think is really working. Just the conversation we've just had, I think, does prove or does show that the AAA methodology does work in terms of bringing things up for discussion. So I think that's one general point. But as to the specifics, no, nothing to add about the Appointments and Remuneration Committee. Thank you.
Okay, thank you. Sarah, anything to add on the Mental Health Collaborative? I think it's actually Jamie who chairs it, but I think Sarah Raystrick attends it from our perspective, don't you, Sarah?
Yes, I think happy with what's listed there. Thank you.
Okay. All right, so the report really just asks us to note the key decisions and items of discussion that took place in the last round of committee meetings that took place. It's really there for transparency to the board around the discussions that have taken place. The committee minutes are also available, and it's to demonstrate the workings of the committees, really, which are obviously important part of the governance of the board. So thank you very much. We're moving on then to the deep dive, which is children and young people, obviously, as we've talked about, and special education needs and disability. Is Daryl with us? Because I think we are due to start that item, aren't we, at 10:30?
Krishni, so Mary is presenting the deep dive.
Oh yes, I'm sorry. That's
the
update, isn't it? Yeah, my apologies. Wrong way round. Yeah. So Mary, are you happy to start?
Thank you, Krishni. We've already had some discussion on this. I mean, SEND is a very complex area. It's not just the responsibility of health, it's the responsibility of education, social care. It's everybody's business, and that is one of the challenges I believe that we have in reporting across multiple systems. But really, SEND is about making sure for the children that have some sort of learning difficulty or disability that we give them the best chance in life, the best opportunities and the best support through their early years to make sure that their life is supported and they can achieve their potential. It's multifaceted, it's very complex, it's obviously distressing for families and loved ones, it can be distressing for the children themselves. But what the important thing is with SEND is that partners and systems work together collaboratively to make it as simple as possible for the family and their child. And the example that Catherine gave earlier is a real example of how it feels for these children and families. I know in Worcestershire we met a number of families and children, teenage children with SEND, and the story they tell of the constant battle that they have to try and navigate services is real. Whilst all services think they're doing the best intentions, they're making the system complex for these individuals, and it's our responsibility to make sure that it becomes very simple for them to access services. The reason we're doing this is not just what I've said, it's because we know that there's evidence-based clinical interventions that can have a real impact on the life of these children. You know, we know that these children grow up and have more ill health, they have more long-term conditions, and that obviously impacts on the health services and partners as well. So this is a big area of prevention that we can do as a system point of view to keep those children healthy. You can see on the bottom of page 2 in the introduction section the impact for our particular ICS. We have more children than most across the country that have a special education care needing care plan. Now, I will come on to later the reasons we believe that that is. And this is a national picture. It is growing everywhere, the number of children with special educational needs, but we have a slightly higher percentage. I'm focusing on this in a number of ways in this deep dive. First of all, so the board understands our statutory responsibilities and how we're performing against those statutory responsibilities. That's really important. The role of the designated medical and clinical officers, again, another really important statutory role that we need to have in place, and how we co-produce with children, young people and their families. I've not been long in the area of children. It's only a few years. I've always dealt with adults. It is a completely different way of working and something that takes more time, more resource to get right. But it's really valuable working with children and their families to understand what's right for them. Just to start off by describing our new governance around children. I mean, 5-10 years ago, I don't think we ever discussed governance of children in our systems. We now have an ICS-wide Children Young People's Programme Board that oversees the work of the 2 place-based, quite strong children young people's infrastructures in both areas. You can see its responsibilities there outlined on page 3 of the report, but particularly in relation to SEND, just want to highlight a few things. It's really, from an ICS point of view, it's overseeing. So every system should have a SEND strategic plan that it supports the 18 to 25-year-old group as well as the younger children. And the ICS programme board is overseeing the implementation and delivery of that. It's also overseeing the place-based work, both in Worcestershire and Herefordshire, and I'll come on to some more detail on that in a moment. But really, it's supporting the collaboration of all the partners in the system, how they're working together to deliver the SEND agenda. They're delivering it at place, but we're overseeing the collaboration and intervening wherever necessary to support improvement. But really, as a SEND partner in the system, particularly the NHS part of the ICS, I would suggest we're probably quite a few years behind the councils, the Department of Education, in the SEND journey. Now, I was in London yesterday. There's a very good reason why the NHS is a bit further behind, and the whole country is further behind than the councils and the Department of Education. But it's our responsibility to ensure we are very visible, very effective and very supportive partner in the SEND agenda. So that's where we're starting off from a governance point of view, and all of this is measured, just so people are clear, by Ofsted and CQC joint inspections that happen at a regular basis across our system. Indeed, they have just the inspection framework has been updated this year. It's taken a step up in its deep dive and its requirements. And we know that Herefordshire are due to go through that imminently. We're just waiting for a date for that SEND inspection. So the partnership activities that are happening at the moment are quite detailed. So in Worcestershire, just for clarity, Worcestershire, just people that weren't here at the time, in 2018, there was a SEND inspection on the old framework. There was a finding of inadequate in that inspection, and that led to the formation of the Independent Children's Trust, Worcestershire Children's First, and a written statement of action which has serious consequences. So it was then re-reviewed in the autumn of 2021, obviously through a period where we'd had the pandemic and some of the work that we needed to do wasn't able to happen. There was significant improvement had been made, particularly from a health point of view in that area, and the 4 areas of the written statement of action that related to health, we were told it was all delivered and developed, and they were happy with that situation. But it did leave an area of more work to do, particularly in schools, for children in schools. And it led to the development of an accelerated progress plan, which has regular monitoring from the Department of Education and NHS England. You can see the 4 work streams of the accelerated progress plan there, and we've got a further review later this year and we are getting a lot of indication from the regular reviews that there has been more significant improvement. So we are hopeful that we will be able to put SEND working in Worcestershire back into mainstream monitoring. I think one of the pleasing things in Worcestershire, there's been the approval of the 120 place special free school. That was one of the key areas. There wasn't the placements for children in Worcestershire. That has been agreed and is now going forward, so will be supported in the future. But apart from that, we are very hopeful. I think the one pleasing thing for myself is the Patient Carer Forum in Worcestershire, which at the very beginning of this process was a very difficult discussion, a very difficult meeting. We're getting much more positive feedback from that Patient Carer Forum, and that's been acknowledged by the DFE and the NHS England as well. And then, obviously, as I said, we wait with anticipation for the review in inspection in Herefordshire as well. We are working with a SENDIAS on page 6, so we jointly commission with the councils an advice and support service for all our population in Hereford and Worcestershire called SENDIAS. It's a free telephone and in-person service to patients and carers using trained advisors. I have to say it's one of the best things I've ever seen, to be honest. It's very supportive of the individuals, and the story earlier, you know, it is for when somebody has got a SEND plan, but you could see it being developed in future for those that are waiting on the journey for understanding if they are going to have a SEND plan or be delegated to SEND, and being that supportive person, it is very, very helpful. Education, health and care plans, another key statutory responsibility is for education, health and the councils to come together to put what we affectionately called an EHC plan in place for these children. Getting these EHC plans in place is a national challenge. You know, coordinating across those services in one single plan that simply describes to the child and their family what their needs are, what the interventions are they require, and how we're going to monitor and evaluate that it's exceedingly complex. We have some delays in our system because of capacity, particularly in Worcestershire. We have it opposite in Hereford. We have good timeliness with the HCPs, but we have some quality issues. We are doing work across the ICS. We've invested short-term funding to try and improve the timeliness. We are putting standards and training, etc., in place to try and support this. But we're having to be quite reactive to the situation at the moment. We want to look at how we can make this sustainable, which I'll come on to later in the deep dive and what we're going to do. There is one of the good things, there was quite a bit of audit going on in play at the moment, which wasn't going on previously. We now will be able to track through the improvements helpfully. But you can see the requests at the top of page 7 for EHCPs have quite dramatically increased. Now that is coming largely from families, not from schools themselves. It's coming largely from families. And it goes back to a bit what Nikki said earlier. Families are seeking external advice, support, guidance from independent companies that are now available. And it's not always mirroring with what, when they eventually see the statutory services, what the requirements is, and that's causing quite a bit of confusion for the families and concern for clinicians. So what we need to do is to be able to meet the demand that's coming through for the assessments, and that's where our focus in the short term is going to be, and the short-term investment is helping us to do that at the moment. Designated clinical officers, it's a statutory requirement of our board to put in place designated clinical officers. They are there to be the senior, most expert SEND advisor from a health perspective in the place-based systems. We have now got one in each place-based system. And we've got a little bit more in Herefordshire with a medical officer as well. They are there to support the frontline clinicians and social workers to ensure that we get the right EHCP in place, and particularly for the complex cases, to support those. There's a whole range of other responsibilities you can see outlined in the report, but we now have in place those DCOs, which is helpful. The co-production aspects, we put in a nice little, we met with a teenager who gave us a very strong view, who said about he was old enough now to be told what's going on and not to speak to his parents. He sounds a bit like my own, really. But anyway, he very much wanted the information in a format that he could understand, and it was targeted at him, not his parents, because he also believed his parents weren't telling him the actual facts. But that, but it was, when we looked at the information that we provide, it was very much targeted at the older person, and was not very clear. So we are working closely with, and we formed a partnership with Action for Children to gather views of the children, young peoples and families, and they're doing that across our whole system, and they're due to provide the report to us shortly. I'm sure it's going to come up with lots of things that we need to improve, but that partnership has really helped us to understand what the children particularly want. We're doing this on a you said we did basis, and we'll take small incremental steps to making the improvements going forward. Very interestingly, some of the feedback has been, we need to be clearer around and be clearer with children and their families, what the clarity and expectations are. What can they expect, because they don't understand what to expect. And we obviously, our services presume they do, because that is causing most of the frustration. So that's something we need jointly to work on with the councils and with the schools in partnership going forward. I've outlined some areas of excellence, and this is feedback from from our assessments, and I'll just pick out a few issues on that. So training, we have now got some much better training in place than we had previously for our staff on SEND requirements, responsibilities. Still more to do. It started in Worcester, it's going to be rolled out to Herefordshire as well, but it's improved greatly from where it has. We have got evidence that health practitioners identifying potential unmet health needs through the EHC process. So it's not just about putting that plan in, we are doing some preventative work and finding health issues that can be addressed as well. And then we are working much better with the schools, SENCOs, or the school education setting there, the staff in there. It's taken quite a long time, but we're getting better relationship with the schools to support them on some health-based work, and specific awareness raising on asthma has been really helpful in keeping children well and hopefully out of hospital with asthma going forward. Areas of risk. So I've picked up the big areas of risk, I think, a lot so far. So demand and capacity for SEND responsibilities. So we have this year particularly, we've had escalated from both places that the capacity to meet the demand has not been sufficient. So hence the short-term funding that has been put in place, and we're just monitoring the outcomes of that. That's particularly on the timeliness of responding to the EHCP. A bit what Kath said in her patient story, that's far too long to be waiting. You can see in the EHCP section itself at the bottom of page 9, we spoke with the statutory timescales we need to meet. We reduced the number that are above the statutory timescale, but it's still at 138, which is too many children waiting for those assessments. So we're going to take a view shortly on, do we need to invest more money in the short term to support this. It isn't just the resource though, I'm sure Sarah and Jane would agree. It's finding the staff, it's the workforce pipeline for things like OTs, physios, speech and language therapists. That is really difficult for our system at the moment. Just want to mention some of on page 10, the neurodevelopmental pathways, so the autism and ADHD. I've outlined for you the work that we're doing. Again, a significant increase in referrals for assessment for both of those conditions. Again, a national issue, not just a local issue for us. We are redesigning our ADHD and autism care pathway and diagnostic process at the moment. We want to make it a much clearer pathway across our ICS, and it will include recommissioning of the children and young people's mental health provision and more targeted support to ADHD and autism. We're doing it in co-production with children and their families. We've been having events running since March this year, and we are anticipating, ready to procure for next year, next financial year, a service and a care pathway that will start to meet the needs. I can't envisage at the moment it's going to meet the full needs, but it's a step in the right direction for meeting some of the demand coming through. I think this will be an iterative process over the next couple of years to meet that demand. We've outlined for you, and I won't go through the detail because you've read it, the areas of transformation that we're doing. I just want to pick out the one area: transition to adulthood. When we've met with these families and the children, particularly the mid-teens children, which I've done more in Worcestershire, haven't done so much in Herefordshire, but I know that's going on. One of the biggest issues is we get all this support as a child, and then we transition into adulthood and all that support disappears. And obviously, if you've had that all your childhood, and as a mother or father, you've had all of that guidance, support, etc., and it suddenly disappears, that is very, very difficult. So it's a national issue again. This is a concern nationally. We're starting in a small way with this. We're starting some youth workers, particularly with children with long-term conditions, of which there are many, which is quite surprising, but there are many. We're starting some youth workers to helpfully transition those child and family through into adulthood. It is showing that some of the adult services are unable to respond in the way that we want to, which is going to be an ongoing issue for us. But we're using this as a blueprint for future developments. So, and we're also supporting. We're looking at the preparation for adulthood, and some of the information that the families get is not where it needs to be. So we're improving that as well. What I want to talk to you about, though, is about this. This is really challenging. It's complex. It's become a very important aspect of an ICB and ICS, and we know our partners want us from an NHS point of view to support more. We were asked to go to London yesterday. It was the new Minister for Children, and they have launched, and we are part of this. It's called a Change Programme Partnership. It's a 2-year national programme launched yesterday by the Minister for Children. There's 9 systems across the country. We are one of these systems, but not just our ICS. We are in partnership with Telford, Wrekin and Staffordshire, Shropshire. It's partnership with Warwick University to support an evaluation. It's led by the DFE, but the NHS England and the councils were very much on the stage launching this together. It does come with some funding for setup costs. But what it's looking at is the complexity of SEND across the country. They feel there's only 2 areas in the country that are in a position to be able to say, we have got this in a place where we're meeting the needs of children with SEND from a partnership point of view. So we will be working in partnership with Telford, Wrekin and Shropshire, and with four big aims. Strengthen our partnership arrangements across the systems, and a new governance model to do that. Very prescriptive, which I thought was great. Others in the room didn't, but I thought was really helpful because it takes some of the ambiguity out of the equation. We will be developing a local area inclusion plan across this new footprint, and this is how we ensure children and young people become included parts of society. It will provide us, I'm sure the providers will think, I can't wait for this, a digital platform and the data and intelligence that will help us. We have not got the data, just putting this report together, we have not got the easy access to the data and intelligence we need to make strategic decisions about SEND going forward. And that's a national issue, that isn't just us as well. But I think most excitingly, the last one for me, it's going to help us to develop strategic planning for early identification and intervention for children at that very young age. A classic example of what Kath talked about, to prevent the need for future services. There are many stories across the country, and there was lots of them yesterday, where if the systems had intervened earlier, the outcomes for these children would have been much improved. And I'm going to use speech and language therapy as an example. I mean, I didn't know this, but apparently since COVID, a lot of new children coming into school are struggling to talk, to interact with others. It's become a major issue. One of the areas in the country invested 2 years ago in speech and language support workers quite heavily in each school, not to be referred to at all, working in the schools. So you took that whole process of referral out of the equation, working in the schools, and the outcomes for improving speech and language has been quite astounding. So they're using some of the Pathfinder work they've done before they've launched this new policy, and I'm going to make it quite prescriptive for systems to deliver. And the reason behind that is they want us to work at pace and not to be, not to be developing these things ourselves, which personally I think is a good way forward. The idea is it will build sustainability going forward, because we can be reactive as we want, but we will not, we need to have these services and this integrated work working ongoingly for the future. There was support generally for a single point of access and contact for families and carers. So that was something that will be part of the plan. And there was, interestingly, given that discussion this morning, but we need better support for people who are waiting in any services to give them better information. It was also co-chaired by the chair of the Council for Children with Disabilities, who gave quite an impassioned plea about, we've got 2 or 3 years to resolve this issue, or we're going to have a major issue with this childhood population over the last 10 years if we don't see improvements. So it felt yesterday it was in our benefits to be involved in this. It's been signed up to, I believe, by NHS England on our behalf, but it did seem like a good programme to get involved in quite quickly, and to work closely with other partners on as well. So I'm aware there'll be place-based discussions in the next week or two on this, just to get the information down, and we're waiting all of the detailed letter and presentation we saw yesterday is coming next week, so I'll get that out to everyone as soon as possible. So that's really what I wanted to say today, and then I'm happy to take any questions.
Great, thank you, Mary. So that sort of brings us right up to date in terms of these discussions obviously taking place yesterday, I think you said, Mary.
Yes, yesterday.
So okay, let's bring a few people in for questions. So first of all, Vicky, please.
Thank you, Mary, for that deep dive, and it shows the complexity and the significant work across our system around children's services. I guess just wanted to explore what your reflections were in terms of the infrastructure, because you talked about the partnership board, you talked about place-based work. Just in terms of the leadership on these issues, do you think that the resources, as well as the workforce resources that are required to make this effective, what were your reflections when you sat there yesterday in London about what was needed to be able to progress this at pace, which is clearly what they want?
Yeah, that was the table's first reflection, and how on earth we're going to do this. So we will be getting setup costs for this, which will enhance our ICS infrastructure for SEND. We will also be getting further personal development for the people leading SEND at system level, because I do think that's needed as well to understand all of the complications around this. We will need, I think our structures within our ICS now, we've taken a while to get there, are as efficient as they can be and effective as they can be. But given the complexity of what we're dealing with, adding a layer with Telford, Wrekin, Shropshire, we've got to make sure we don't lose the place-based implementation, because that's really important. It needs to add to that. So whatever resource we get, whatever people we get, and there is a partnership they're bringing in with someone called Reach, an external partner, and that they'll bring in as well. We need to make sure it doesn't divert from what we're doing currently. We did raise a concern. I'm sure Jane and Darryl are thinking, we've got an inspection coming up in shortly. That has got to be our priority as well. We can't deflect from that.
Thanks, Mary. Can we take Aman and David to get it, not together, but one after each other, and we'll bring you back in, Mary, to respond to those just in the interest of time. Aman?
Thanks, Krishni. Yeah, Mary, I'd just like to acknowledge all the hard work and that's gone into this, and also, the report was really helpful and very comprehensive. So thank you for that. I've just got a couple of questions. One of them is probably for my benefit. It's what is considered timely in terms of health advice for ECHPs? That I'm not familiar with this area, so I don't know what's too long, what's not quick. So some context around that, and also, are we sure, or are there children out there that perhaps need that have special educational needs and need a healthcare plan that we don't know about because there might be other barriers in place? Do you have any sense of that? I was just thinking, when Kath was talking about Theo and his mum, that she was able to navigate through the system. What if someone's got a language barrier? How would they, what support is in place for them? So just those two questions from me, please.
Really good question. Mary, can you store that and I'll come back to you, because I'd like to add to that as well. David?
I would like to add to it as well. Great questions, Aman. So covering part of the ground I wanted to cover as well. On page 7, Mary, we see the EHC NA requests, and there's a very, very different level between Herefordshire and Worcestershire. And I wondered what your comments were on that. Is there a demand that we're actually not seeing in Herefordshire, which is already being recognised in Worcestershire? So I wanted to understand why those are different. And secondly, there's just one small reference to CAMS on page 13. And I keep hearing across the country about the funding problems that CAMS have. So I wondered if you could give us any input, any information about the resourcing level for CAMS and whether CAMS is actually being resourced to an appropriate level in our 2 counties.
So Mary, I think there was a question about the timeliness of what we're doing, I think, from Aman, and barriers to accessing SEND. Are there barriers within communities? And that, to be honest, was one of the things that I was concerned about. Is are there people we don't? I think Aman said, are there people we don't know about? So when we're engaging with Action for Children, for example, are they reaching our more seldom heard communities within Herefordshire, Worcestershire, to understand whether they are able to access those services? So I think that broader question. And then the CAMS, there was a question about demand, I think, as well, which linked to that perhaps, and then CAMS funding. Is that okay, Mary? Are you comfortable to come back on those?
Yeah, okay. Thank you. So firstly, if it's all right, colleagues, what I'll do is send out to you all the statutory requirement timescales, because it's quite complex to describe. I'll get that sent out to you very quickly, so you've got that in front of you. Okay. The aspect of the SEND numbers and are we outreaching to everyone that needs it? There is national belief that there are far too many children that are getting to that SEND position because we haven't intervened early. That is one issue, but there's also a growing parental understanding of the benefits of having that SEND care plan in place, particularly in schools. Which is a constant challenge with schools. Daryl's much more expert than I am on this, but it's a constant challenge in the schools. Are we reaching diverse populations? I think that's a very good point. I don't think the intelligence tells us that at the moment. I think it's something we need to look into further, and maybe as part of this change programme we could feed that back in, because it wasn't mentioned yesterday, to be honest, at this national launch. So that's something we could helpfully feed into it. I think from it, I haven't seen it. I haven't noticed the diversity in Worcestershire. I've worked mainly in Worcestershire on this one. I haven't noticed it at all, to be honest. So I do think that's a really, really good point. From all the work that we did with GPs in Worcestershire a few years ago now on SEND, when we introduced it, it was more parental understanding of when a child should be talking, when a child should be walking, and the slightest delay in that causing an issue. So very well educated parents coming forward, and that's a national that's been seen nationally. So I think that's a really good point, Emma, and I'll feed that back into the improvement plan. I've not seen that at all. The requests for EHCPs that David mentioned. So obviously, given the difference in population size, you'd expect the referrals in to be very different. But I do believe there is a much greater understanding of the Worcestershire population of SEND and it's starting to grow in Hereford as well, Darryl, isn't it? Definitely, but it seems to be a few years sooner in Hereford. I know particularly in the schools in Worcestershire, the growing understanding has caused a significant pressure on social care, healthcare. The growing demands have been significant. And then CAMS. I think, you know, maybe Sarah and Mark might be better answering this one about. I know we've invested more in CAMS because of the demand, but the autism and the ADHD pathway definitely require more CAMS support than maybe we have currently. But I know there has been some significant investment, and Sarah might be able to, for Mental Health Collaborative, say where we are on that.
Thank you. Sarah, do you want to come in?
Apologies, my mute button wasn't cooperating then. I was going to ask a slightly different question, but it does link with what Mary just said, and I think she's answered it to a degree. But just to say, clearly the demand for EHCP reports and assessments is significant and growing, and has certainly really expanded post-pandemic. But obviously we do get referrals from a whole range of sources into that pathway, from nurseries, from schools, from primary care, from parents. But I think it's a real area we need to be very minded on as an ICB, because certainly the opportunity to increase inequalities is strong in this area. But you do find that schools and nurseries are very minded around that area and will make sure children are referred. But there is significant wait, and I think it is very distressing for parents and families. And clearly the EHCP very directly drives support children get in school. So it is really important. And often if I get correspondence from families around this area, it's because of the importance maybe the child's transitioning between primary school, secondary school, etc. And actually families are really keen to fast track some of the support that might be required before they move. My question was more around the change programme and trying to understand how it will reach out to all communities and make sure we try and address the inequalities, but also how much co-production will be possible in that programme, Mary, to kind of shape how we approach this moving forward. So that was my question. But just on the CAMS point, I do want to just mention the West programme. So the Mental Health in Schools programme is one of the key areas for mental health investment under the MIS investment monies, and we have prioritised that programme. It's almost an area where you struggle to keep up with the workforce, to keep up with the expansion that's possible from the national funding. So we've got national funding coming out in waves to support mental health support in schools, and I think that programme is really critical around tier 2 and early intervention and picking up and advising and working alongside school staff, as Mary referred to. A lot of the speech and language therapists do already. So I was just going to make that comment about the West programme, but my question was more around the change programme, Mary, and how much it will engage families and help them redesign to a degree what happens in that early phase while they're waiting for assessments and going through the process.
Mary, if we can briefly respond, because I think we're a little bit behind now.
Yeah, there was a very strong message from the national team that co-production with families and children will be very much part of this. On the flip side of that, though, Sarah, the families and children nationally are telling them every area does things differently, and there's no one positive way of doing it, and they want to help design one positive way of doing it across the country. And so that was very much the message to the national team from children and families.
Thank you, Mary. Simon, I'll bring you in a moment. I think it sounds like this is a really, it's a really complex area. It's that this latest development is really positive. I do think we need to understand you know, the consequences of sort of not addressing special educational needs, the outcomes for those young people can be incredibly significant. Having briefly worked with educational providers and schools, particularly, you know, I've never forgotten a conversation I had with a pupil referral unit. I don't know if they're still called that, but that was what it was called some years ago. But these were children who were excluded from school for a variety of reasons, and he was involved in a number in quite an area, and he said almost all of those children had special educational needs that had been unmet prior to them being excluded, and exclusion is a significant risk then in terms of what it then does for the child or young person's journey. So I've sort of, that's always stayed with me as something that can be, you know, really start a young person on a really a journey that is not, you know, ideal at all for them. So I think this is a really important area, but very complex, and it does, I'm assuming, Mary, that there is a sort of correlation between actually people know that they need an EHCP in order to get those needs addressed, but there's then, if they're concerned about ADHD, is driving the demand for ADHD diagnosis, presumably, in order to establish a plan. So am I right in thinking there's a link between those, that demand that it's creating?
Yes, definitely. So, you know, there's more awareness of ADHD, more awareness of autism, more awareness of learning disabilities, and the more of that, it's definitely increasing the demand.
Yeah, and as you said, it's increasing post-pandemic as well. So yeah, really important. Lots of positive things going on. Clearly, more information to follow, I think, Mary, around what happens next. I would really like you to take away that point about diverse communities, though, and people with other barriers to access, because I read a report. In reading your report, I found very easily a report on intersectionality, as it was called, and SEND. And actually, it was very clear that there is, you know, if you actually draw that Venn diagram with special educational needs and people who might have other protected characteristics, those people find it harder to access services. And I think that's something we should be concerned about, because, as Sarah said, I think it could be driving other inequalities. Simon, final word from you?
Yeah, just two comments really as part of wrapping this item up. So firstly, this is complicated. It's an enormous agenda. I would reflect that we've probably spent more time and management time and energy on this in the last 2 or 3 years than in my previous 15 years collectively in the NHS. So it is clearly something that is gathering prominence and importance for us. It's right that we're talking about it today. We don't have all the answers, but we do have a lot more understanding than I think we've ever had of the issues and what we need to do. And we're building our capacity. We need to keep building our capacity and understanding. But yeah, I've seen significant changes in that in the last couple of years. And secondly, and importantly, as we look ahead, this is an area that is going to require investment. We are going to have to put capacity into a number of these areas. We are going to have to work out how we target things like the mental health investment standard into this area. We are going to have to align capacity around ADHD and autism, because that's really closely linked to this. And I suspect one of the things I know Mark and the Chief Finance Officer are talking about is, can we reserve almost a pot of money, a set of resources that could be invested into this area over the next few years, because it clearly is a significant increase in energy that's needed and attention on this. The only question, of course, for the board is that investment will have to come at the expense of something else. So this is a classic area. We talk a lot about left shift. We could almost apply left shift to the life cycle, that we want to be spending more money on children to intervene earlier to prevent some of the issues that we've talked about. But we have to understand the impact of this on our medium and longer term financial planning as well.
Yeah, thank you, Simon. I think that that really sort of brought that to a helpful conclusion. So we note the progress, Mary, that's been made in delivery of this, and the developments that you've now outlined, which are hot off the press. Clearly there are a lot of risks here, but I think the fact that we are giving this this significant focus is really important, and we thank colleagues who are working on it. I'm really conscious that we probably need a little bit of a break. I welcome Daryl to the meeting to talk about the next item. Daryl, would you mind if we just took a short 5-minute break, and then we can start your item? Does that work for you?
That's fine by me, thank you.
Great. So if we reconvene at 11:15, just to stretch our legs and get some refreshments, we'll kick off with Daryl then and motor on the rest of the agenda. So thanks everybody, and we'll pause the meeting there. Welcome back, everybody. I make it 11:15, so let's kick off. And Daryl, welcome again, and we'll hand over to you for an update on Herefordshire Children's Services. Thank you.
Thanks, Christian, and good morning, colleagues. So if you recall, we provided an update report earlier this year on the inspection report itself and the improvement plan that was at that time signed off. So this is a brief update on where we're at currently, and in fairness, the brevity of the report probably doesn't accurately reflect at all the depth and breadth of the amount of work that's going on across the service and across the partnership at the minute. When a local authority is judged to be inadequate by Ofsted, they are then subject to anything between 4 and 6 monitoring visits over a 2-year period to monitor progress against the improvement plan and against the recommendations made by the inspectors. And of course, we've got an improvement board which is chaired by a DfE advisor, and we're the subject of a statutory intervention notice still. So the governance and the monitoring of the improvement plan per se is all channeled through the improvement board. We've had 2 of those monitoring visits so far, with a third one planned for next week. But of the 2 that we've had so far, we've actually had some constructive and helpful feedback from Ofsted. On both of the visits so far, they have seen and acknowledged improvements since last summer at the inspection. And I think particularly pleasing was the amount of progress that had been made in the multi-agency safeguarding hub, which was the subject of considerable concern last summer when inspectors came and children were waiting for far too long in some instances for a multi-agency response to risk. So that's particularly gratifying and pleasing, and a lot of people across a range of agencies have worked particularly hard there. I think when you look at the 2 appended feedback letters, you'll certainly see that we're trying to improve. We are improving from a low base, so the quality of our practice still remains variable. There are pockets of an increasing pockets of good practice and improving practice in parts of the service, as well as what you would expect at this point in our improvement journey as being the reminders from Ofsted of what more still needs to be done. The focus of our 3rd monitoring visit, which we are planning for next week, will be on looked after children and permanence planning. So that will include a health for looked after children and referral pathways, something you've touched on earlier in your meeting agenda today. I think it's fair to say that all the data is pointing to something of a reduction now in demand in a number of areas. During 2021-22, we saw significant rise in demand, which put a huge amount of pressure on children's social care services and some of our partner agencies too. Some of that, I suspect, can be attributed to the impact of COVID and lockdown and other elements there. And certainly in your other agenda item, there's a lot of evidence that that's contributed to a rise in referrals around anxiety for children, for example, and your CAMS conversation earlier. But also that also typically happens after a significant event like an Ofsted inspection, or in our case a High Court judgment. You see that rise in demand coming from a range of sectors. That's now certainly been plateauing for quite some months. It now appears to be starting to tip, but the levels of demand remain higher than certainly pre-COVID levels for us, and that's a challenge, and it's a challenge for all agencies, not just for children's social care. So we are seeing increased numbers of children on the child protection plan, for example, still, although the numbers are coming down. If anything, there's an observation I share in the report that whilst the demand appears to be coming down, there is still increasing evidence that as a partnership we are still risk averse. That we seem to be trying to escalate children through early help, child in need, child protection looked after at quite a rate, almost perhaps with a belief that children are somehow safer when they're on a child protection plan. And whilst it's certainly the case that some are, it's a bit of a false safety that goes with just the fact that a group of agencies sit around the table and meet together. And then some of those children cease to be on a plan within 3 months or 4 months. So again, maybe those plans could be managed at an earlier level of intervention, which was more proportionate for families and is arguably a better use of resources across the ICB and ourselves and others. So there's a plea there really to keep having a conversation about how we intervene earlier and better, so that we avoid those higher cost and more intrusive interventions for families. And again, that resonates with a couple of your agenda items today, I think. There's been a lot of focus on the numbers of children in our care. And I'm pleased to report that the rate at which children come into our care has significantly reduced over the last 9 months. And in fact, in terms of the numbers coming in through the front door, we're now at a lower rate than statistical neighbour in England averages, where we were a significant outlier in the opposite direction a year ago. There are still a higher number of children in our care than you would expect to see in a local authority this size, and that's partly as a result of children that came into our care in the past and have become long-term looked after. There is a lot of activity going on at the minute where it's safe and appropriate to consider reunification with families, and certainly we've discharged 8 care orders already in August, and there are plans to discharge a further 24 between now and the end of December. So again, that requires a great deal of reassessment, agencies working together, coming up with the right plans, but doing the right thing for families where their circumstances have changed and where it's now considered to be safe and appropriate that a child could go home again. And that always done through the court arena too, for that level of assurance and safety that goes on. I think on the same note, we have certainly seen an increase in the numbers of unaccompanied asylum seeking children coming into our service in the last 6 months particularly, and that's in part because of the pressures on Kent and the National Transfer Scheme, but also the emergence of asylum hotels in a number of local authorities, including Herefordshire, over recent months. So that kind of slightly balances out some of the numbers in terms of our looked after children, where we're pushing down demand in terms of local Herefordshire children. We are also hosting and receiving an increasing number of unaccompanied asylum seeking children in Herefordshire, which again is something as a partnership we should be thinking about and cited on, because there are pressures there on universal and specialist health services, education, social care and others, and not least among communities themselves. The recruitment remains our single greatest risk. We are trying to be creative, increasing welcome payments and offers, and thinking about how we work on that, but too high a proportion of our workforce remains locum. We have some incredibly good locums, to be fair. Certainly don't want anybody to think that locum equals bad. We've got some really good locum social workers and managers, but actually about too high a proportion of the workforce is locum, which isn't good for stability for the service. It isn't good for families if they're changing social workers. And you will know that there's a premium that goes with employing agency staff as well, which is a pressure on budgets and scarce resources. Most of my middle and senior managers now are all permanent, which again is a big change from where we were at the beginning of the year. You will hopefully have seen, and it is appended to the report, the recently published commission that was convened to consider families' experience of children's services. This was part of the Commissioner's recommendations to the Minister, and how we look to listen to and hear the experience of a number of families who were speaking at public meetings and clearly had an experience to speak of. I would encourage all board members to read that report if you haven't yet had the chance. Whilst it's predominantly about children's social care, it is also absolutely about and references other agencies, including the police and health. And I've certainly said to my workforce, it is essential reading for you. If you work with families, you need to read this report and think about this report. It's hard to read, and for that reason, it's important learning for us. We've embarked now on a long-term improvement relationship with Leeds Children's Services. Leeds, if you're not familiar with them, had similar challenges that we have now, but some years ago have come through that and have twice now been rated as outstanding by Ofsted, and have achieved a great deal of success in a number of areas in terms of working with families and with partner agencies and the like. So I'm really excited about that partnership. That's focused at the moment on introducing restorative practice as our practice model. So relational practice, building relations with families and other professionals, and working with rather than doing to, which again has been a criticism of children's services in the past. So happy to speak more about those. I think there was a question earlier on about how are we learning, which I picked up when I was in the room. Are we learning about from the experience in Worcestershire? Yes, we are. We try to learn from all local authorities that are also demonstrating improvement. Leeds being the key, our key partner in this relationship. But we're doing some joint work with Worcestershire on a couple of projects, particularly around working with the courts and looked after children. So, you know, Worcestershire are an important neighbour to us, and we try to foster and develop that relationship. And happy to stop there, Chair, and take questions.
Thank you very much, Daryl. Any questions for Daryl? David first.
Yes, thanks, Krishna, and thanks, Daryl. You know, that's we often use the words welcome report. Yeah, I really welcome that report because it shows just how much work is going in. A couple of questions and a comment really. One is, when you look at the feedback letter, the first feedback letter clearly is quite kind of quite positive. The second I thought was not quite so encouraging. So I'm glad that there will be another visitation next month, which will allow us to kind of measure progress. Which brings us to the first question of, are we actually on course and following the agreed trajectory in terms of improvement? So are we kind of on course for that? That's my first question. And my second is really a kind of comment about just to again be pleased that your senior management now are no longer locums, because although temporarily kind of increased welcome payments and things like that might help, we all know that what really keeps people in the job is actually the leadership that they have and how they're supported by their line management. So I'm really pleased that you seem to have permanent people in those roles now who can develop that.
Yeah, thanks for the feedback and questions, David. I think if I'm being honest, there are parts of the improvement plan where we're progressing at a faster rate than even I was hoping. There are other areas where I have some frustrations that we're not making the progress as fast as we'd like. Obviously, I've said recruitment is a challenge for us, and I think that is a barrier to improving as fast as I would like to see at the moment. Similarly, there are also some issues which others in the room will know in terms of multi-agency data sets and things that we need to develop if we're going to really focus in on what difference do we make for children and young people. I think all of the infrastructure planning stuff is absolutely on plan and on track and on trajectory. We've made huge strides there. I think we're still at the stage where it's early days in some areas to see the impact that it actually makes for children and young people, and of course that's what the Ofsted focus is. They're less bothered about the activity, although it's important as an infrastructure and a basis. Their question ultimately is, what difference do you make for children and young people? And in some parts of the service, it's still relatively early days to see some of the impact that we still want to see, because we're kind of laying that groundwork down. And yeah, I absolutely agree with you. Welcome payments and the like are okay as far as they go, but ultimately people often stay. There's lots of research that people stay because of good supervision, good line management, and the culture within the organisation. And we're focusing very hard on changing and building a positive culture in the organisation.
Great, thank you.
Thank you, Daryl, and thank you, David, for the question. Katie, I just wondered if you wanted to comment at all. I mean, I know obviously there's also risk, isn't there, that we focus on the NHS workforce, but I know the People Board has had some previous focus on our social care colleagues, and I just wondered whether you have any reflections. And I know you're not doing another recruitment fair, aren't you? So I just wondered if you wanted to comment really on that.
Yes, thank you. Yeah, we talk about all elements of health and social care in terms of our workforce. So the People Board is a cross-system board, and we talk about it there. And we have talked about social workers actually previously. I don't think we were ready to do a cross-system approach to that yet, but what we're hoping is that the approach that we will bring to the board next time in November of Grow Your Own might be an approach that we can use for other critical workforce groups, and I'd include social workers within that. And that's a conversation I've had with Tracy Sampson, the HRD in Herefordshire Council, and also with Richard Taylor in Worcestershire County Council. And yes, let's just do a quick plug actually for our workforce recruitment fair next Wednesday. That's going to be held in Worcestershire this time. We do alternate. We do it in Herefordshire as well, at the Worcester racecourse. and we'll be advertising a whole host of different roles across the system there. And if you're listening publicly, if you'd like to come along, do bring your CV, do come and meet us, because we're very excited to meet you. We'd love to have you in our system.
Thank you, Katie. Good opportunity for a plug. I have to confess, I watched the video of the last one and I was amazed by the range of roles and organisations represented at the fair. And had I not had something else I needed to do that day, I was going to pop in and say hello, but really important, because, you know, that is literally a cross-system event, which is really everybody working together to support that recruitment. So I think that's really, really important. Thank you, Sarah.
Thanks, really helpful to see what's outlined there. Just a couple of quick points. The first was sort of in your executive summary, you made reference to sort of risk-averse behaviours amongst some partners, and it's a question really about within the recovery plan how that's been addressed and whether we've seen any improvement there. That's obviously a very difficult one to do, and obviously that reflects through to some of the things you were telling us about the number of children on a child protection plan potentially. And then just to pull through, thank you for attaching the family's experience report. The sort of the 20 family or the 20 people there, only one was a child, so it's some assurance really that we're listening to children's voices in this as well as adults. And my final bit was in that report as well. It did talk about none of the families there had asked for help were given early help interventions of the 20 people that came through, and I just thought that was quite striking really, and it's again some assurance that the early help offer is being addressed and is robust enough for families when they seek help. Back to what we were talking about before, really at that earlier stage of need. Thanks.
Thanks, Sarah. So in terms of risk averse, so we're doing a lot of work across the partnership in terms of making sure that there's a shared and common understanding of our threshold document, which, you know, Ofsted and others, you know, I think there's a general agreement. It's not the threshold document. The threshold document's fine. It's the interpretation of that. And in my personal view, it's about professional anxiety by and large. This sense that, you know, children are safer if they're on that level or that level, and it's about, I hope that each of us as system leaders and our managers and our safeguarding leads and the like, we just keep having those reflective conversations and think what's going on for this family, what's going on for the professionals around the family, and what's the least intrusive and most appropriate intervention for the family. Yeah, don't forget, once a child's on a child protection plan, there's a stigma attached for the family, for many families there, and then there's a statutory responsibility on a range of professionals and partners, which is a valuable resource that we need to make sure is targeted at the right families. So that's the kind of reference there. There's only so much that we alone as children's services can do. The whole partnership and the system needs to reflect and think about what's going on here in terms of the system and professionals' behaviour and the like, to make sure that it is genuinely the right help for the right child at the right time, and that it's proportional in terms of level of risk. And the indicators and the threshold there is, you know, the imminent or significant risk of harm rather than the potential for. And again, we can sometimes get stuck on the potential for and then label children and families in the wrong way. Listening to children, yeah, the Commission really wasn't set up and geared for listening to children itself, although one young person did present. There are many more groups that we're running now particularly for children in care and care leavers, but other groups as well that we run from a site in Hereford, and that's gathering pace. That's an area where we knew we needed to do a lot more in terms of gathering feedback from children and people. We need to get a bit more into the space, certainly around collaboration, and making sure that we're making decisions as a leadership team based on having listened to the voice of children and young people in the process. So more to do, but again, better than we were at 6 months ago. I think I feel less positive about, I'm generally glass half full, but I struggle with and feel less positive about the early help offer at the moment. I don't think it is good enough for parents and families. But I'm also really clear it's not a Herefordshire Council issue in its own. So we do have a duty to ensure that there is a early help offer and some targeted early help support. We've got a good team that's been, you know, appraised by Ofsted and by Leeds, but in fact, the early help arrangements in Herefordshire are multi-agency arrangements, and I was listening to part of your debate and conversation earlier on about SEND and CAMS and a whole load of other stuff. There is something about how do we step up as a group of partner agencies to provide either different arrangements going forward, or make sure that families really well understand the arrangements that are already in place. And I think there's a lot of feedback that families don't necessarily know what's there, and particularly in parts of rural Herefordshire, how you access some of those services. But you know, there's an increasing. An example, I was listening to a family yesterday telling me very clearly that they had made referrals to a health service. We won't go into specific teams or services. That, you know, their child is very, very, very anxious, and they were being told reportedly, you know, contact the early help team in the council and ask for a family support worker. You think that's actually not what my early help team's for, but there's a wider issue there, isn't there, about how we respond to what appear to be growing levels of anxiety at the moment. So I'd welcome more of a conversation and a debate about where we would all want our early help services to be in a year's time or 2 years' time, because I think they fall short at the moment.
Thank you, Darryl, and thank you, Sarah, for the question. And Mary, I wonder if we can, I mean, that sort of conversation about, you know, our collective effort around early help, etc. It sounds like it could fit in. I don't know whether I'm being too optimistic here, but to the work that it looks like we're going to be doing together as part of this other initiative, jointly with Shropshire and Telford, I think you said. So, because exactly. you were clear that health and social care together, we're going to be running that. So. Is that right?
Exactly. One of the objectives I said earlier is about looking at how we can do early intervention and early identification, and we've got that's one thing we can do. So we'll discuss that outside this meeting about how we progress that. Great.
Thank you, Mary, and thank you very much, Darryl. That was really helpful. And you're right. I think the report of the Commission in terms of the experience of families and children, it was a really important report for us all to read. Obviously, we're here collectively to work with you on this, and hope your next, I think you said in shortly, isn't it, next week maybe, that you're having a revisit, if that's the right term. So hope that goes well.
Next week's our third monitoring visit, certainly. Yeah. Good. Thanks for your support. Thanks for your time.
Thank you. So we note the report, and I think we've sought a number of questions connected to the previous discussion as well. Right, we'll move on. So we've got our system quality and delivery report. I think, Mary, that a lot of the things that are in there, obviously things we're quite familiar with and were covered also in the reports from committees, but so briefly, maybe if there was anything you particularly wanted to draw our attention to, or an update on anything in there, perhaps we can just focus on that.
Okay, thank you, Krishni. Thank you. There's just two things out of this report to highlight, and I'm sure either Katie or Kath will take any questions on the workforce and the quality issues. Just urgent and emergency care. So winter preparations are ongoing. Indeed, we're arranging a QRD plus a non-executive member briefing, detailed winter assurance visit presentation for you all, and ourselves. We're being monitored by the region on our winter planning as well. Urgent care challenges remain, particularly in Worcester, but I have to say, for the first time, I'm seeing lots of work around the key aspects, like a single point of access. We've now got a plan for November. That's more progress than I think we've made. So the plan for November is to have a single point of access in Worcestershire, which I'm sure our primary care colleagues will welcome very quickly. So there is progress being made. We just need to get it done as quickly as possible, so the new ED has a real chance to be successful, and that's the point from there. On elective care, just to update you, so we're waiting for official notice, but the tier 1 in Worcestershire is being de-escalated to tier 2, which is fantastic news. A lot of hard work gone across the system, and that's the whole system. The ICB, Wye Valley have helped out a lot. Worcestershire itself have done a lot of work to get us to this position. Still a challenge to reach the 75-week target by the end of the financial year in both places, largely because of the industrial action and some of the bringing forward of the targets nationally. So we're supposed to have all first outpatient appointments by the end of October for those that, you know, would potentially breach the end of at the end of March. That is really challenging, given industrial action, working hard to do it, and there's a few specialties that we're struggling with, but there is a good working approach across the system to deliver that. And just lastly, dermatology, the briefing, I've just seen it pop in my inbox, so we'll be sending you out the dermatology briefing today or tomorrow once we've read it through to make sure it covers all the aspects. And work is continuing to make sure we've got a safe dermatology short-term service in Worcestershire whilst we wait for Herefordshire to start that lead provider arrangement across our system. So nothing else to add from the report. I think it's quite clear, but three of us happy to take any questions.
Thank you, Mary. Any questions or comments? Okay, sounds like everyone's reasonably happy with that report. You know, obviously really positive, Mary, to hear about the progress on electives, and it was encouraging when I was at the chairs call. I think Russell was there as well, and actually across the region, I think for the first time we weren't actually highlighted in any of the slides as from an elective care point of view, and I felt some reassurance around that. But obviously it would be very good to be de-escalated somewhat, but obviously more work to do. I think, you know, that's a step in the right direction potentially, isn't it, for us? But always more work to do, because we know we want to minimise the waiting times for our patients in our community. So that's you know, really important. But I just wanted to note that, because I think it is positive, and we do need to recognise the efforts that people have put in to get us to that position. So thank you very much for the report. And in the absence of any other questions, I think we're just asked to note the ongoing challenges around various aspects of the care and the actions that are ongoing, and of course the high level update on quality and safety and workforce issues. So thank you to colleagues who contributed to that report. We move on then to item 13, which is financial plan and delivery. So over to you, Mark, please, for that.
Brilliant. Thank you very much, Chair, and good morning everybody. So I'm going to update on the financial position now up to month 4, which takes us up to the end of July. So just as a reminder for board colleagues, we had a deficit plan that was submitted for 23-24, 19.2 million deficit plan. So as a result of that, we were given mandated financial controls, which I can assure the board we've now got fully in place across all organisations, and we've just recently had to do a self-assessment and provide evidence of that to our regional NHS England finance team. So just picking up on month 4 then, so the collective position is at month 4 we have a £25.7 million year-to-date deficit. So at the moment that is £9.3 million above the phase plan of where we thought we would be. So if we remember our financial plan, we have a deficit position for H1, so that's the first half of the financial year, and then we move into a surplus position across the system for H2, so that's for the second 6 months of the year. If you look at within the report, then you can see that of the 9.3 million, 6.4 million of that variance sits within Worcestershire acute hospitals, and 2.8 million of that variance sits within the ICB. So within the report then, across pages 4 to 7, you'll see we've analysed out each of the different organisations within the system and what the drivers are of their financial positions. I can summarise them quite quickly as elective recovery fund assumptions, because as at month 4 we still hadn't had any information about what we refer to as ERF, the elective recovery fund actual delivery against that. There's plan phasing issues specifically within the Worcestershire acute plan that drives part of it. We've got ongoing insourcing and outsourcing, which is supporting our elective recovery work, but again, that comes at a financial cost. We've already talked earlier about ongoing industrial action. Whilst that has lots of other implications, that is giving us a financial impact as well. And we are seeing excess inflationary pressures over above the funding that was received from NHS England. So whilst it's welcome in today's news that inflation is starting to come down a little bit, the costs we are seeing so far are driven by that increase in inflation above what we were funded. So within month 4 then, efficiency and agency position does remain a key risk and driver of what's behind some of our financial variance. So at month 4, efficiency is collectively off plan by 2.8 million. We're behind where we said we would be, and agency expenditure is 2.5 million above the plan that we submitted. Specifically then, when you go into the ICB part of the plan, the main driver there is prescribing expenditure. So at the time of preparing month 4, we'd had 3 months worth of prescribing cost. This is GP prescribing. So this is the actual cost of the drugs that patients are prescribed when they visit their GP. Those 3 months worth of costs are 11.3% above the same period in 22-23. Now, we were only funded for a 2.9% price uplift, which was in line with the national planning requirements. So you can see it's the price that is driving our problem there. Prescribing volumes are down, so we're down overall as a region, across the region, and also on the overall NHS England prescribing volumes that are there. Also mentioned within the report, and we touched on it briefly, is around the medium-term financial plan. So there is a lot of work going on at the moment looking at financial planning and a route back to balance, but also linking that to operational planning for 24-25. We talked previously as a board that we have an underlying financial deficit. That's part of what's driving the in-year problem that we have, but underneath that, there is an underlying financial deficit that we need to address over the next 3 years, or if possible, sooner than that, as we start to get ourselves back to financial balance. We're working through those plans at the moment. We've got a number of workshops coming up with colleagues. So when we know a little bit more about the outputs of that and what some of those plans look like, we will continue to come back to the board with those updates. And again, as to how we approach that with NHS England, because this is going to be a multi-year recovery plan as we start to get our financial position back into a balance. I suppose within month 4 then, if I just go back to the current financial year, the plan that we've got at the moment isn't without risk. There's risk in terms of we're off plan at month 4. We're doing a piece of work at the moment looking at where we think the forecast outturn might be, but at the moment we are continuing to report the delivery of our financial plan, which is the 19.2 million deficit. I suppose the way I would break it down is there are 2 ways to look at this. There are uncontrollable costs, so things linked to industrial action where we just need to make services safe, where there are costs linked to excess inflation, which are above what we've been funded for, and we'll capture those and we'll continue to work with NHS England on how do we address them. But specifically within our system and our plans then, there are costs that are more controllable. So efficiency, we all signed up to efficiency plans that were submitted back in June, and we collectively need to work out how we recover that shortfall and deliver them. And likewise, agency, we made some big steps in terms of wanting to reduce our agency expenditure. That's coming through in terms of all the work that's been done around workforce and addressing how we deal with some of that. And Katie, I'm sure we'll come back later months to talk about some of the ongoing strategies and things we're looking at there. But at the moment, our agency expenditure is still a little bit too high compared to where we thought we would be. So again, from a controllable aspect, that's within our gift to look at how we bring those down. So if we can bring those elements down, again, it puts us in a it's not an easier position, but a much more of a position where we can talk to NHS England about how do we address some of the things that are outside of our control, and how can we get support to deal with those going forward. So I would say that's where the finance plan is at month 4, Chair. Hopefully I've covered all of the aspects in there in terms of the key messages. We've tried to include as much as we can in the report to make it very comprehensive for the board and for public reading it, but I'm happy to take any questions or comments, Chair.
Thank you very much, Mark. Graham, please.
Thanks, Krishni and Mark. I think that the new format report looks really good and very clear. Just a couple of quick questions for you. The last couple of reports have referred to the deep dive, and it strikes me that that's going to be quite sort of pivotal in our financial approach for the rest of the year. Can you just describe to me very briefly the form that that's going to take and just the timing of it? Because I think you're referring to it as being on month 6 numbers, which would make feedback to the board here in November, which might lead to a very compressed timetable if any actions were necessary. A second point, Mark, just going really briefly because I'm not cited on it. I know we've got the investment and expenditure committee, and because we're in a deficit position, have they made any changes to any of the patterns of expenditure that we had otherwise planned that needs to be reported back? And finally, just a question about the dental clawback. Has that position changed? Are we still incorporating a benefit? I think it was about 1-point-something million in our plan.
Mark, do you want to come in on those? As there were several points there, I thought it might probably, to be fair to you, to try and address those quickly.
No, that's fine. So in terms of the dental clawback, nationally that's not been resolved yet. It is being discussed with through regional finance directors up to the national finance team. And there is an expectation that as it's a delegated service that sits now within the overall ICB, that any underspend that is accumulated in that area should remain with the ICB. That's still being worked through. In terms of the I&E subcommittee, what we've got there is the mandated financial controls. We're looking at 3 areas. One around any non-clinical vacancies. One around any new expenditure above £10,000, so that's new spend that wasn't in last year's run rate, and then the third being around non-clinical agency requests. We're working with all partners through the controls they've got in their organisations to look at, are there opportunities around mutual aid, are there opportunities to potentially redesign or share posts. Each of the organisations that are doing a very good job at working through these controls. So what we see at the I&E subcommittee is the output of anything that has gone forward for approval, but there is lots that is being declined and not supported from an organisation perspective that's not even coming forward for the subcommittee to look at or consider. So the controls in the organisations are being fully incorporated into the business as usual day-to-day running. In terms of the deep dive, then we're about to kick that deep dive off now, Graham. So we've kind of pulled it forward a month. We're starting specifically with Worcestershire Acute because that is the biggest area that is off plan. And if you look at some of the metrics, a number of the metrics are in the wrong direction. So we're starting that, and I know that Worcestershire Acute are doing some internal work through their finance and performance committee of how their financial run rate is looking. So through the deep dive, through their own internal work, we can continue to report back, Graham, on that. We will probably initially go back to the ICS Finance Forum with all system partners around the table, but we can do a specific briefing for the board on anything that we think is of concern that might continue to put pressure on the financial position and run rate, and might mean that our overall financial forecast does need to be reconsidered throughout the rest of the financial year.
Thank you very much, Mark. Thank you for the questions, Graham. David, please.
Thanks, Krishni. Mark, unusually for me, this is a single part question, and one which I've asked last month as well, and I think it's important for us to address it each month, which is, given the financial challenges that we're facing as a system, can we as a board be assured that patient care will not be adversely affected by the financial challenges that we're facing at the moment?
That's a really good question, David. From a finance perspective, we're not putting any changes through or making any decisions that would impact on patient care. Things, for example, like industrial action that we've already talked about, we just accept the cost will be the cost to keep services safe. Anything that does require any changes, we would have to look at a quality impact assessment. An equality impact assessment, we would have to go through the proper process before making any of those decisions.
Great, thank you, David and Graham, for the questions. I think the key message, Mark, is we've got to control the controllables. And the key points in that, I think you were talking about, were our commitments around efficiencies and also agency. And I think it's fair to say that the region did reinforce that to chairs earlier in the week around those areas. And to be fair, I think most systems are in the similar position in terms of inflationary pressures and cost of medicines and some of those things which are incredibly hard for us to be dealing with, costs of industrial action. But efficiencies that we've committed to and agency, we've just got to demonstrate that we have done everything that we can to deliver on those. And I think that's the ask of us. Thank you, Mark, for the report. If there's nothing else you want to add, I think you just want us to note the position at the moment and the actions underway to manage those risks, which are very clearly articulated. I did find the report incredibly clear and helpful. Thank you. I think Graham commented on that as well. I know you'll be keeping us all up to date on developments on this. So thank you, Mark. OK, we have a couple of final items. So we have a board assurance framework report and a fit and proper person test, both of which are sort of governance issues, really. So first of all, Hannah, on the board assurance framework report.
Okay, thank you, Krishni. So the board assurance framework you will be really familiar with by now, and you will know that it summarises all the ICB priorities. It sets out the success measures and any associated risks. So clearly there's a huge amount of detail and content within the board assurance framework, which I'm not going to go into. Many of those issues will have been discussed today at some point during the meeting already. I just wanted to really, and I say this every time, but I just want to sort of highlight this is the top of the governance pyramid, really. There is an awful lot of work and oversight going into this through the individual level 1 and level 2 meetings. So the programme boards and the committees have got a really good oversight of these documents and regularly monitor and challenge these risks. And you will have seen that, for example, coming through the AAA report that we have presented to the board earlier. So just one thing in terms of process, really. So we have refreshed our objectives, as you know, a couple of board meetings ago. So this framework now reflects that. We have tried to get under the skin of the assurance ratings a little bit more. So rather than having an overall assurance statement for each priority, we've tried to break that down into success measures. The obvious question and next step now is, how does it align with the ICB oversight and assurance framework? The answer is we are working on that, and in time the board assurance framework will be aligned, working in line with the 4 levels of assurance. So I'll pause here. Happy to take any questions on any part of that.
Thank you, Hannah. Any questions or comments on the board assurance framework and the associated document? I think this is subject to scrutiny at audit committee, isn't it, as well? So
yeah, I should have said that there's a meeting coming up in October, and I'm sure the committee will analyse this in quite some detail.
I do find the framework detail very helpful and easy to follow. I suppose the only observation, and not, just really a question, I suppose, not one to answer now particularly, but there's been no change in any assurance since the last review. So I suppose it's just that question of what's going to make the assurance level change, and is there what's the time frame for doing that, and is some of that going to take quite a long time, in which case there's an element of sort of understanding what risks we're having to tolerate, I suppose, for at a certain level?
I'll answer that really quickly. Some of this is a process thing, Krishna, in the sense that we've refreshed the framework. So because we have got to refresh priorities, there's nothing exactly to measure it against. And I think, you know, we have gone through this process of sort of evolving the process. I think we need to stabilize the process to really be able to see the month-on-month improvements that we make. So that will be the plea probably to audit committee, is that once we sort of, if we are happy to settle on this framework and this particular kind of representation of it, I think we need to then monitor it month on month. So it's not necessarily the difference hasn't changed. I think the graphs kind of just show that we've not really got an awful lot to compare it against because our priorities have evolved and changed.
Thank you, Hannah. Useful, and I think as long as we're focused on how we're going to drive that change, I think that's the important commitment, really. So thank you. We'll take that as helpful assurance and note that the audit committee will be reviewing this again in October, I think you said, Hannah. So the final item is a fit and proper test, NHSE guidance and implementation. In the interest of time, I think we're not going to go into detail on this, but thought it was really important that it was in the public domain. I think, Hannah, we felt it was important that people understood that this new guidance was going to be implemented, and there are various milestones that we're going to need to hit from September, end of September onwards, and those are set out in the paper. So in the context of some of these other developments, I think strengthening the fit and proper persons test is an important development. Hannah, is there anything you want to particularly add in terms of how we go forward?
I think that was a great summary, Krishna. I think it is exactly as read, really, that paper.
Thank you. I think the one thing we will need to do, which Hannah does highlight, is how we work with partners in particular, which is different slightly in relation with the ICB versus providers, just in terms of how we implement it with partners in a kind of proportionate and sensible way. So that's just something we'll need to work through with you. And the only other thing I did want to note is that all directors will be subject to a new appraisal framework, so that will affect pretty much, you know, most people, if not all, everybody on this call, and albeit it could be within, you know, different organisational settings. However, I did note, and I've seen some advice from NHS England, that they are we're not expected to implement the full appraisal framework by the end of March, but that we have got some time until June. So I just wanted to note that, although they are saying that they would expect the annual review of fit and proper persons and the appraisal to align in future years, but I believe that we are going to have a bit longer to do the appraisal. So I just wanted to note that. If no one's got any further comments or questions on that, it's really there for transparency and noting, and the fact that we'll be taking that forward on that basis. So thank you, everybody. That concludes our business for today. I really appreciate all the work that's gone into the development of the papers and the reporting, and thank you to everyone who contributed to the discussion. Our next meeting is scheduled for Wednesday, the 22nd of November, online as usual. And for those colleagues who are invited to a confidential meeting, that will start shortly. So I look forward to seeing you there. Otherwise, thank you very much and have a good day. Thank you.